Hello, I'm Dr. Brenda Hasselbrock with Health Source Chiropractic of Houston and Memorial. And today we're doing a training video on the Health Source Chiropractic Pediatric Exam and history. Dr. Bullock will be leading the training today and demonstrating for us. Dr. Bullock is a DC, Doctor of Chiropractic, and a CA-CCP, which means she has completed her coursework to obtain the diplomate in chiropractic pediatrics and pregnancy. Take it away, Dr. Bullock.
Thank you. So I want to go over really quickly the history form because the history is really important. We'll talk about birth traumas, things like that, but those are all really important when it comes to a pediatric exam. Depending on how old the child is you're examining, I'm assuming most of them infant, toddler, when we use this form, otherwise you would use a different form. So when you're going through dizziness, ADHD, and you're going through this whole list, it's really important to really kind of latch on and find out, if they circle one, really find out what that's about, because everything kind of ties in with kids. Systems tend to tie together. When they have ear infections and then they circle ADHD, those things tend to tie together. So really dig into that. There's a place for a pediatrician. Really follow up with the pediatrician. It makes the parents more comfortable, and it's a really great way to network what you can do for pediatrics and what you can do for them. When you're going through prenatal history, if they write anything with complications of birth, especially prematurity, C-section, forceps, any kind of traumatic intervention, make sure you latch onto that. Ask about jaundice, ask about their APGAR scores, and some parents may not know them. So, and that's okay. Birth weight and length, things like that. Definitely find out if they're breastfed or formula fed. That makes a difference with immunity, and that makes a difference with the response to your care too, to some degree, when they're that little. So really latch on to food allergies, things like that, especially if they're having reflux or if you're seeing them for some kind of stomach issue, whether it be constipation, reflux. Really kind of latch on to what is, if they're formula fed, breastfed, or whatever. So especially if they are formula fed, find out the formula, find out how many different ones they have tried, if they are on soy formula versus dairy formula, and really dig into that, because kids typically, if they have an allergy to something, it can definitely show with reflux, it can show with bowel issues, it can show with a lot of different symptoms. So don't discount food allergies. Developmental history, sleeping, naps, really kind of dig into that. With kids, sleeping, going to the bathroom, there's not really a place for how often the child goes to the bathroom, but it's really important that you ask that. Breastfed babies can go days without having a bowel movement. Formula, most likely not. If they're toddlers and they're eating solid food, they should have a bowel movement every day. And even some degree breastfed babies should too. So, so definitely find out about that, because that's all going to contribute to your overall care. Childhood diseases and vaccinations, I really kind of want to touch on that, because we're asking about vaccinations and the parents are going to check, most of them will check at least some of them. This is a really great teaching opportunity for you to dig into side effects. You don't have to preach to them, you don't have to tell them you don't agree with their decision. I definitely would caution you against doing that. But I would really want to encourage you to use this as a teaching opportunity. Have there been any side effects? And then list them, because you really want them to be educated. And so many parents, they trust that if the pediatrician recommends it, that it's the best thing for their child. And as chiropractors, we know that that's not necessarily the case. So, and then always get consent to treat, because they are a minor. So we're going to start the exam portion of the video. I really want to start by emphasizing that appearance is a major component of this. So after you've communicated with the mom about what's going on, what the problem is, you really got to rely on your observation as a doctor. So I know the form goes over skin color, symmetry of the face, things like that. And I definitely want you to look at that, but I'm more or less concerned about orientation of the body. There's some primitive reflexes over there on the form, and we'll go over that too. So first thing, the baby will be supine, so it'll be face up. It can be on the mother's lap. It can be, your mother can put her hand on the baby's tummy if the baby is crying. I mean, we can really do this in any position, but ultimately it's supine. You're going to look at leg lengths. Baby's going to want to bring the legs up. That's okay. Kick the legs, bring it down. Leg length, you're going to look at leg length, you're looking at folds of the skin, you're looking at toe in, toe out. If you're looking at the baby's legs like this and ones like this, you're going to want to make notes of that because it's going to tell you a lot about what's going on in the sacrum. Infants aren't going to have as much of this going on as when they get a little older and they start crawling and the sacrum starts becoming a bigger issue. So, and also when you have digestive problems and things like that, you always want to look at the toe in, toe out and what's happening here. Find out if one leg has more tension than the other. They will not straighten one, or one just feels like it flops down. Definitely make notes of that. And I think that there's a place to make notes on the very back, bottom of the form. And so I suppose you could use that. So when you're checking for fontanelles, it's important to know when everything closes. There's the anterior, which will be right here at the top, and then there'll be the posterior fontanelle here. And there's a few others, but these are the main ones. When you're checking cranial sutures in the baby, this baby is a doll, obviously, so you really need to follow the line of the cranial sutures because some babies that are in one position a lot, in the car seat a lot, you'll start to see the back of their head will flatten out. You'll start to see metopic ridges form where the frontal bones will overlap. That happens a lot in premature babies. You'll see areas here where you're looking at the cranium and it just doesn't look symmetrical. Well, that's important because that can affect certain conditions. Like, for example, latching on. Latching on, a lot of times, if the baby has a super flat back of the head, then sometimes when you do some cranial work, the latching on gets considerably better. So it's something to think about. So I know on this side of the form it has some places to do measurements. After you do your observation, I suggest you do that first before you go through all the reflexes, because you really kind of want that to be accurate, especially because even though it has a place for head circumference, I'm also going to add that you should measure, especially if you can look and see some discrepancy in the baby's head, and this is really common. You should measure from the middle of the forehead or the top of the eye, where the eye bone is, to the back of the EOP. I want to say EOB, doing too much insurance lately. So I measure on the side and then compare them. So the form jumps around a little bit, but that's okay. Blood pressure, temperature. You can, with temperature, feel that their body is consistent. Again, if they've got a lot of ear infections going on, you're definitely going to want to test all that. Okay, let's go through some of the reflexes really quickly, so you can see what I'm talking about. So for the rooting reflex, it has some age ranges. Given those are ish, so if the baby's 5 months old and still rooting, that doesn't mean you have a problem. It's just those are ish. So when you've got an infant, when you get close to their mouth mouth should go toward whatever's stimulating the side of their mouth. Right? That's called the rooting reflex. That's a normal response, and that's going to help them latch on. When they suck, the sucking reflex, again, in some states, I'm not sure all of the states exactly, but there are some states where you can't enter mouths, even of infants. So if there's a latching on problem with the mom, you may have the mom do this, but you would use a little finger cover and just gently go on the side of their mouth and figure out what's happening, how they're sucking, because they'll automatically suck your finger, and you want to make sure that it feels equal, that the tongue is being involved, and it just doesn't feel dysfunctional. And you can feel it when it is, because it just doesn't feel like there's a strong grip on your finger, if that makes sense. Okay, so one of the things I really want to mention are some of the primitive reflexes. It says chronic neck on the form. I prefer using ATNR. It's the same thing, it's just the way you... So basically, when you turn the infant's head to one side, their arm straightens, and sometimes their leg straightens, and they bend on this side. All right? Pincer, ATNR, chronic neck, whatever you want to call it. So you turn, these straighten, these bend. Same thing on the other side. Turn, straighten, bend. Okay, that's a normal response. One of the other things I want to mention at this point, so on the form it has reverse Spencer, and then you drop down like 5 tests, and it has vertical suspension. Those you will do those together. So For example, I'm going to have Dr. Brenda be my mom with infants. And you may choose not to do this. There are a few tests on here that I don't typically do. And so if you'll just have a seat facing that way. So just basically, you know, you don't want to put the baby through all kinds of trauma, but you definitely want to find out what's going on specific to the problem. For vertical suspension, this is a really good test, but a lot of doctors are really uncomfortable doing it, and a lot of parents don't really understand. Up until about the age of 18 months, kids generally enjoy it, unless there's something going on. So, and consider it this way: they were like this for 9 months in utero. So basically, you have mom support the baby's head, you support the baby's legs, and I want to actually kind of disclaimer this first. During your examination, if the mom mentions any hip dysfunction, this is not an appropriate exam. So with hip dysfunction, again, it's toward the bottom of the form, but Ortolani's click is what you would be performing before this test. So Ortolani's, you're looking, the leg, you're bringing it up, and you're just feeling it in that socket, in the acetabulum. You're doing it on both sides. If you feel a clunking or if it just feels like it's not symmetrical, then I wouldn't perform this exam because you've got some hip dysfunction. Ortolani's is a hip dysplasia test, and although that's not very common, it's not unheard of either, and so you definitely want to address it. So for vertical suspension, what you'll basically do is just bring the baby up and look at what's happening. The normal response, given you're only doing this about 5-10 seconds tops, the normal response is the head should be straight. Again, you've got mom in front, so if you've got the baby this way, the baby's going to look at mom. So ideally, you're looking straight at mom. If their head cocks back like this, there's some occipital stuff happening here. If they don't like this, if this makes them uncomfortable, they cry, that could be a sign of intracranial pressure. So there might be some cranial work that you may need to do. If their head cocks to one side or the other, this is upper cervical involvement. And keep in mind that infants are going to have a lot of upper cervical involvement because they're not crawling, they're not walking, but they are looking back and forth. You are, when they latch on, they're moving their head. There's some head movement. So upper cervical is going to be very common in infants. So while you're in vertical suspension, you're going to perform the reverse Spencer. All you do is drop one leg. When you drop this leg, the baby's reflex is to look toward the side of the release leg. You straighten out, next leg. And then you have the mom help you support the baby back down. This whole process should take 10 seconds or less because it doesn't take much to see what the baby's head is doing. So that's vertical suspension, and I think it's a really important test. It's just you have to be comfortable doing it because if you look nervous, the mom's going to be like, okay, you're about to do what? So, thank you, Dr. Brenda. For Palmer-Grass digital response, again, primitive reflexes, when you put your hand in the center of the baby's palm, they should latch around it. If you start tipping on the baby's fingers, they should do a grasp reflex. It's pretty self-explanatory. Babinski, keep in mind that there's also a plantar grasp reflex. So if you're going to try to do Babinski by running your pin in the middle of the foot, you're going to get a false negative. It's around the side of the foot and up. And that toe should go up. Y'all should know what Babinski's is. Placing, I'm going to lift the baby up. So placing, with infants, you bring their shin, the front of their leg, to a table, to something, and they automatically lift their feet to lift it on there. That's a normal response. If they don't have this response, there's some spasticity going on, as with the tonic reflex, the one where you bring your head to the side and they should draw out this way. If they're not doing that, there's some, there's a sign of spasticity. You're going to see babies that have mental challenges, Down syndrome, things like that, are not going to be able to do a lot of these tests because they just don't have the muscle tone. And so that's just something that ultimately you're looking for a symmetrical response, but you're looking for some kind of response, a muscle tone. Everybody's not going to be different. Some of them you're going to be like, was that what I'm looking for? But as long as you get a response, that's what you're looking for. I really want to emphasize that because a lot of people just don't see children all day, every day. And that's going to affect how you interpret some of these exams. Parachute, when you bring the baby here and you hold the baby, again, you're going to have mom kind of support this. They automatically want to lift up. They want to lift their head. They want to lift everything up. So you're looking for that response. For Morrow, this is the scare reflex. You bring them down, you drop them. Okay, let's rephrase. You don't drop them. You just lower them quickly, and their response should be, their arms should come from here and it should flail out, right? Catching themselves. Acoustic blink, they should blink their eyes. When you clap in front of their face, they should blink their eyes. Or when you snap their hands and you make a sound near their face, they should blink their eyes. So then there's the contractions, abdominal, anal, cremasteric. I think abdominal you're looking for specific dermatomes. So if you are concerned about actual nerve function, then by all means, turn the baby over, pull the diaper off, and do the anal reflex. But I'm not sure it's necessary if a baby's coming in because they have reflux or irritation. So neck riding, before I forget it, when you turn the baby's head and part of their shoulders to one side, they turn their body. So before, what happens is you turn their neck to the right, you'll get the extension, and then if you continue to keep them in that position, they'll turn their body. So it goes from the ATNR to neck riding. So that's what that is. So when I'm actually doing the contractions abdominally, you're looking at the baby's abdomen, their umbilicus, and you just basically stimulate the abdominal muscles, and you'll feel them tighten their stomach. Same thing, cremasteric, obviously this is on a male child. It's the front inner thigh, and you should see that muscle contract. With anal, again, you have the baby turned over with their diaper off, and you have to get pretty close to the actual anus, and it should contract. For deep tendon reflexes, with kids, is it necessary? I don't know, but ultimately, if you've got some positive exams or positive tests here, it's maybe warrant a check. But keep in mind that if I'm doing a patellar reflex, the baby is not going to kick me. It's easier to use a very supportive grasp so that you can feel the slight movement that you're going to get. And I'm talking slight. So you would perform those, and the eglotations, you could perform them on an adult. It's not complicated. For heart and lungs, listen to them, listen to their heart, listen to their lungs. That's really important. Infants have typically really strong hearts, so lung problems, breathing problems, that's going to be something that you're going to really want to pay attention to. Lymphatics, when you do their exam, again, I kind of would typically do this at the beginning of the exam, observe, palpate, feel the baby, and then do some exams so they're familiar with my touch before I start dangling them and things like that. So again, same area that adults have lymphatics. You're going to want to go under the chin, behind the ears, in the suboccipital region, down the neck, under the arms, feel the baby. You're basically just going to feel the baby. When you get in the abdomen, it doesn't really go into palpation of the abdomen, anything like that. Listen to the abdomen, but also palpate. If they have chronic constipation, you're going to want to feel them and see if that baby is highly uncomfortable. Because you'll know, even if with a really young infant, if something you're doing is uncomfortable. Because I'll let you know. If you want to be careful of the direction you're palpating, because again, you could stimulate something on the table. So when it comes to palpation, it says liver, spleen, kidney. Again, just palpate the abdomen, and if there's hardness or discomfort, write it down. Eyes, things like that, if they should be able to follow a toy. And that's also how you're going to get, with a little bit older babies, how you're going to get active range of motion. Either have mom or you bring a toy, and kids will follow it. When you go into the upper extremity, really palpate the clavicles, because when children, during the birthing process, a clavicle fracture is so often missed. And it's not, and they don't consider it a big deal because there's not much they can do for it. So even if they catch it, a lot of times they should say something, but you would be surprised in some of the studies I read that they don't say anything to the parent. So palpate, and you'll feel if there's a fracture, there's something there, you'll feel a bump. That's how your body feels. There's going to a callus. So you just feel it, make sure that there's nothing that's really uncomfortable for them. Bring their, you can do arm motion at the same time. Again, when you pull on a baby's arms, they're going to want to bring it forward, and that's a normal response. Hand structures, again, look at structures, look at joints, look at the shoulder joint. You're looking at infields. They all should be springy. Children are very bendy, very flexible, so you should feel springy infields on all the joints. If it feels like it clunks in or something, then there's a problem. So you're looking at the ankle, looking at the wrist. I mean, you just kind of go through. Alignment, wrist clonus, I don't really know what that's about. Lower extremity hip motion, again, I would do this before all the infant reflexes just so I could understand Ortolani's alignment. Barlow's, ankle clonus, okay. So you're bringing this to make sure if you can bend the baby's legs forward so there's no meningeal irritation. So again, when babies run high fever, the first thing they're really afraid of is meningitis. So that's going to be an important one to bring forward and make sure that that's not something that's going on. Neurological examination. Again, most of this neurological thing you're going to cover in the infant reflexes. Flaccid paralysis, spastic contracture. You're going to see the differences in the baby from the norm in the reflexes. APGAR scores they may or may not know. And motor system function. Also, the parent will know if there's been any change in their child. So cranial nerves, when it comes to that, olfactory, okay. Optic, can they see you? Look at the eye movements, look at the facial expressions, look at the way they interact with mom, look at the way they move their shoulders. You can really kind of, the ones that you can test, you can get through fairly quickly. Leg length and gluteal squeeze. Okay, leg length again I do at the very beginning of the exam. Where you're looking at leg length, you're looking at toe in, toe out, and there's not a place on the form for that, but there's a place for clinical comments that you should utilize, because if they have a toe out on one side, then they have an ion in ilium. If they have a toe in, it's an EX ilium, and you're going to want to address that, so it's going to create problems in treatment. The gluteal squeeze is a really fantastic exam. So again, most of the time when babies like this, it's an infant, they're on the mother's lap, or they have the mother here. They don't have to be laying face down to get a good gluteal squeeze. You don't have to take the diaper off, just bend it down. And so you're bending the diaper down, you're looking at the very top of the gluteal crease, and obviously the mother will be holding the infant, and you're just going to squeeze the buttocks together. And that line should go straight up. So if it goes over to the left or over to the right, there's some torque of the sacrum. So that's something you should be aware of. You look at the gluteal folds. If one gluteus, like the fold where the butt, you can see the butt turn into the leg, if one is lower than the other, there's some sacrum stuff going on. There's some ilium stuff going on, so you really need to address it. Heel to buttock, again, same thing as pulling the arms around. Just you're looking at tension. Leg lengths, again, I do this at the beginning of the exam, just because it's part of my initial evaluation. When you're looking at passive cervical range of motion, really whatever position the baby's comfortable in. If they're okay still continuing to lay supine, then move their head around. Then use a toy. There's no active range of motion, but use a toy because you really kind of want to see what they're able to do on their own. Passive lumbar range of motion, choose their legs. Bring it around. Have the mom stabilize them while you're doing this. Palpation, again, I do this more at the beginning of the exam. Just go through and feel muscles. I always recommend my moms start baby massaging when the babies come home. Tummy time and baby massage, I'm a little bit on those, because so that they really get to know their baby's body, but also it's really good for lymphatic flow and all of that. So complicating factors I want to mention for a second, because this should be discussed in the history, but 3 or more ear infections in the last year, on multiple courses of antibiotics, birth trauma, or interventions like vacuum, forceps, things like that. Those are going to be bigger complicating factors. If a child's been on multiple antibiotics, recommend a probiotic, and yogurt does not count. And I'm going to repeat that. Yogurt does not count because it's not the same. Obviously, these will be a little older children are going to feed a baby with yogurt. If they're premature, prematurity should be on there also because you're going to have very specific things with prematurity, and 15% of the population is premature. So you're going to have a premature baby, and the mom may or may not even mention it, so you have to ask because reflux is going to be a bigger issue in prematurity. Premature closing of some of these cranial sutures are going to be bigger issues, things like that. Colic, you're going to get a lot of. Colic, it's just take care of the baby and the colic goes away. Digestive, acid reflux, all that. You're going to get a ton of reflux. So make sure you're evaluating the baby properly. And then segmental dysfunction, again, when they're, based on age, when they're really tiny, you're going to see a lot of occiput, a lot of C1. Depending on how the baby is born, if it's a vaginal birth and there is some pulling on the head, you're going to have, I mean, I feel like there's almost always stuff going on at the occiput. And you can feel in the suboccipital region, you can feel fogginess on one side versus the other. You can feel whether you can, if it's restricted or not on children. I think I've gone through the majority of the exam.